Reactions and anaphylactic shock, 2023, Tyler Webster. Allergic reactions and anaphylactic shock, page 12 of your SOP book. Local reaction and mild systemic reaction is going to be a mild reaction. Vital signs are stable, no airway compromise. Moderate systemic reaction, signs and symptoms occur in 2 or more symptoms. I have the list further into the PowerPoint. Occur rapidly, vitals are stable, normal mentation. Critical, severe systematic reaction, anaphylactic shock. Signs and symptoms include 2 or more systems, occur rapidly, vitals unstable, alter mental status. Those last 2 things are highly important. Initial medical care, special considerations. If airway is compromised, go immediately to medications. If airway is compromised, skip immediately to the critical. Repeat assessment for airway patency, edema, wheezing, and respiratory effort. Try and get their past medical history if they have an EpiPen, and then ask about their anaphylaxis emergency action plan. Traditionally, if somebody knows they are very allergic to something, they'll give you a heads up. And if they're not aware if they are super allergic to something, obviously they're not going to tell you, but also that is a good sign for hopefully this isn't going to turn into anaphylaxis. Apply venous constricting band proximal to bite or injection site if the swelling is going up rapidly. Attempt to identify and remove inciting cause. If you need to, wash it away, wipe it away, remove a stinger, remove a piece of clothing. Apply a cold pack to the bite and injection site unless contraindicated. Do not start an IV, give meds, or take blood pressure in the same extremity as a bite or injection site. Local reaction is going to include isolated hives, edema at the site, GI distress after food ingestion, observe and transport if they want to be transported at all. Vital signs remain stable. No airway compromise, nasal congestion, sneezing, periorbital swelling, rash, itching, tearing of the eyes, and lung sounds clear. You may provide Benadryl, 1 milligram per kilogram, up to 50 on this. IM injection or the pill. It does say IV push for Benadryl. A big warning that I have for people: if you are going to be pushing Benadryl through an IV, it is my experience that if you push it rapidly through an IV, your patient will vomit by the time the plunger reaches the bottom of your syringe. Please, please, please make sure this is more than 30 seconds. Bare minimum, more than 30 seconds. Try to make it out over a minute or two. Of high importance, they will vomit very fast if you push Benadryl too quickly through an IV. Some localized hives, the periorbital, I can't even get it out. Periorbital, I tried. Swelling on both eyes, and then nasal congestion on the right. This is moderate. Signs and symptoms in 2 or more systems occurring rapidly after exposure. So these are the systems here on the left: skin and mucosal tissues, again, itching, flushing, hives, swelling, edema, your mouth or throat, drooling, edema of the airway, swelling of the lips, tongue, uvula, larynx, and soft tissues, tongue and throat itching, respiratory, dyspnea, trouble breathing, cough, bronchospasms, wheeze, stridor, hoarseness, chest tightness, hypoxia, GI edema, so some swelling, dysphagia, abdominal cramping and pain, diarrhea, nausea, vomiting. The moderate systemic reaction, your vital signs still remain stable, your blood pressure and MAP are over 90 and 65 respectively. Your first step is going to be epinephrine 1:1 IM 0.3 milligrams in their leg. They're cautioned if the heart rate is over 100. We do have to evaluate whether the heart rate being over 100 is due to the stress of having an allergic reaction or not. So provide the epi based off of your clinical findings. Hypertension, on beta blockers, digoxin, MAO inhibitors, or pregnant. Those are cautions, though. They're not reasons to not do it, just cautions. May repeat every 5 minutes per required need. Do not delay transport waiting for a response. Consider the need for CPAP. If they are wheezing, albuterol 2.5 milligrams and ibuprofen bromide 0.5 milligrams via handheld neb or mask. Add O2 6 liters nasal cannula if you need for additional oxygen. You can run the albuterol and ibuprofen through your CPAP. And then again, the diphenhydramine 50 milligrams IV push. If no IV, give IM. PO if no airway compromise or vomiting. Some hives, more of a systemic hives. GI upset on the top right. The bottom right is drooling. The bottom left is a cough. Critical, severe systematic reaction, anaphylaxis, shock. The above, meaning the issues that are listed above, as well as severely impaired airway and dyspnea, decreased absent lung sounds, cardiovascular collapse, hypotension, adult blood pressure is under 90, or a 30% decrease from baseline, dysrhythmias, altered mental status, presyncope, syncope, or coma. The above refers to the list of symptoms that, we'll go back real quick. There's skin and mucosal tissues, mouth and throat issues, respiratory trouble, and GI issues. That is what that word above next to anaphylactic shock refers to. So you need to have two systemic systems involved. And then also low blood pressure, hypotension, altered mental status, syncope, presyncope, dysrhythmia, severe airway compromise, low if little lung sounds, and hypotension. Initial medical care, special considerations, resuscitate before intubate. Immediately upon our arrival, prior to looking for an IV, if you can assess that somebody is having an allergic reaction, you're going to want to provide them with epinephrine 1-to-1, 0.5 milligrams IM in their thigh. So prior to starting an IV, the first thing we're going to do, we show up, somebody's stung by a bee. Oh no, they're getting anaphylactic. We're going to hit them with half a milligram. So 5 mLs, or sorry. Yeah, half an ml, not 5 mLs, half an ml. 1 milligram and 1 ml, 0.5 milligram IM. If awake and spontaneous ventilatory effort, consider CPAP with at least 5 to 7 centimeters PEEP. If respiratory distress persists and CPAP is contraindicated and not tolerated, you may intubate. You should intubate. Patients like this are going to have swelling in their airway. You're not going to have great intubation sites to begin with. Your landmarks are going to be swollen. So please be aware that you're going to have one decent attempt at intubating. And if you absolutely have to go back at a second attempt, there is going to be vastly more swelling because introducing a King Vision blade is going to create more swelling to begin with. So make sure you're giving the tube over, not to the person who has the least amount of attempts on your crew that day. Make sure you're giving it to somebody who is very confident and competent at their job intubating. Attempt vascular access after the epinephrine IM. If no IV or IO, may repeat epi 1-to-1, 0.5 milligram IM every 5 minutes. Max total dose of 2 milligrams. Additional doses, call online medical control. And then don't forget with the CPAP, if needed, you can give that albuterol neb through that. As soon as the vascular access is successful, normal saline consecutive 200 ml IV fluid challenges up to 20 ml per kilogram. Goal of a systolic blood pressure of 90, reassessed after each 200 ml, plus epinephrine 1 to 10, titrate in 0.1 milligram IV push every 1 minute to a total dose of 2 milligrams. Reassess your patient after each 0.1 milligram. So we're going to give 20 total mLs of epi 1 to 10 every minute for transport. So after we start an IV, which happens after we do the epi 1-to-1, 0.5 IM injection, we're then going to start an IV. Once we start the IV, we can do 1 to 10, 0.1 milligram or 1 ml every 1 minute to a total dose of 2 milligrams, so long as your patient is showing signs of improvement. titrate in as needed. So if they do start to have a blood pressure going up, pulse coming down, they're starting to appear like they're calming down, that they're not progressing into the anaphylactic shock, into cardiovascular compromise, um, reassess your patient about how much you need to titrate prior to your total dose of 2 milligrams. If they are on beta blockers and not responding to epi, you can provide glucagon, 1 milligram IV push or IO, as well as IM. If they are wheezing, I think we addressed this a second ago. Your CPAP, you can do an albuterol and ipratropium, handheld neb and mask. You can do a 6 liters nasal cannula for additional O2. And then Benadryl, again, same dose, 1 milligram per kilogram up to 50. You can provide it through the IV or IM. If cardiac arrest occurs, begin quality CPR. Prolonged CPR indicated while signs and symptoms of anaphylaxis resolve. Give IV fluids as rapidly as possible, plus epinephrine per the cardiac arrest SOP. Here's just a couple of signs and symptoms as well as that list again. Skin and mucosal issues, mouth and throat issues, respiratory issues, and GI issues. On your upper left, I have a picture of an airway, swollen versus not swollen. Again, their airway is going to have some swelling, so be careful when you're intubating. Same picture, different person, same picture idea down below. Another airway with some swelling in it. To the right of that, there is a list of common foods that people are allergic to, as well as a person who is unconscious. And then to the right of that is a kid that is tripod breathing or having dyspnea. And then there is also a blood pressure being taken, trying to elicit the point of low blood pressure and altered mental status are the issues and the line we draw for the critical anaphylaxis shock. Thank you very much. That's all I have for you today.